Hi, this is Dr. Kevin Kirby. We're going to be doing the fifth in the series on root theory versus tissue stress theory today. And today's discussion is going to be on the history and development of the medial heel Skive technique, which is now being used in foot orthoses around the world. I started podiatry school in 1979. In the summer of 1979 at the California College of Podiatric Medicine in San Francisco. During my second year or sophomore year of podiatry school, during our biomechanics rotation as second year students, one of my biomechanics fellow at the time was Richard Blake, who was a podiatrist, and in his second year of Biomechanics Fellowship, which I eventually did again 3 or 4 years later, after he had gone into private practice, and I became the only fellow. At the time, Rich was very interested in treating runners, and he had started to experiment with inverting the heels and the casts of foot orthoses in order to try to invert the orthotic to decrease pronation-related symptoms in runners. And being a sophomore student, I was just starting to get into the MO lab, or mechanical orthopedics lab, where we made orthotics, and many of us in the class of 1983 at CCPM were runners, and and Dr. Blake, Rich was asking us to come in and help him make some of the orthotics. And so I got to see firsthand some of the development that he made in this Blake orthotic technique. And what Rich had found is that if he was to invert the orthotic more, he would start to see less pronation of the foot, especially during the first half of stance phase in running. And he was using this to treat things like patellofemoral syndrome, medial tibial stress syndrome, and such, versus the traditional root orthotic, which was a vertically heel balanced orthotic. And in fact, at the time, during my second year, from 1980 to 1981 at CCPM, root theory preached that the orthotic must be balanced vertically unless their maximally pronated position was inverted at the heel. So this meant that people with medial tibial stress syndrome, patellofemoral syndrome, plantar fasciitis, peroneal tendonitis, posterior tibial tendon dysfunction, and all these diagnoses were treated with the same basic type of orthotic, other than we would just bounce it vertical, and if they were inverted in their maximum pronated position at the calcaneus, we would bounce it inverted. So Rich started to explore on his own with the idea of inverting, and this was totally new for us as sophomore students, since this was totally different than what we were being taught by John Weed and Chris Smith and the other clinicians at CCPM. And what Rich finally came up with is the idea that he was going to be balancing the orthotics either 15 or 25 or 35 degrees inverted. And so the orthotic would have a very inverted heel cup to give more varus control, but then he also would fill in the arch of the orthotic, because he found that if he didn't fill in the arch, the patients would slide laterally off the orthotic. Another thing that Rich Blake did in his Blake Inverted Orthotic design was to add in a standard plantar fascial accommodation, since he found that as he started making the arch higher and higher, the medial arch higher and higher, there was more plantar fascial irritation, so he would add in a standard plantar fascial irritation. The other thing he would also do is make a fairly deep heel cup of approximately 20 millimeters, and he would also make a flat rear foot post. These orthotics ended at the metatarsal neck level, typically without a top cover and forefoot extension. And Rich at the time was actually talking to Merton Root about these ideas, and Dr. Root, to give him credit, was actually said that this was a unique orthotic, and that the experimentation he's doing is vital to understanding if they're going to work and if they're going to cause problems. However, Rich Blake got a lot of flack from the other biomechanics professors, many of them who thought he was not he was going to be hurting people by doing the Blake orthotic, because they knew, at least from what Root had taught, that orthotics should be balanced with the heel vertical. So as a sophomore student, and then later on as a senior student, I was making Blake orthotics on occasion for Rich and for my own patients. And then also when I got into my Biomechanics Fellowship, the same fellowship that Rich Blake had done during 1980 to 1981, I did from 1984 to 1985, and I also was using the Blake Inverted Orthoses on patients with more pronated feet and patients with running-related symptoms related to excessive pronation. The problem with the Blake Inverted Orthotic technique was that it required a lot more time to prepare the cast. You may be spending almost a half hour extra on a pair of orthotics to do the plaster modifications to the positive cast with the Blake Inverted Orthotic versus the standard Root type orthotic that didn't require such extreme inversions of the foot. The Blake orthotic also would tend to, if you went 35 degrees inverted, would be fairly narrow, so you had to widen the orthotic artificially because of the inverted shape of the orthotic. Anyway, so my experience then from my sophomore year through my junior year and senior year at CCPM, and then on in my year of making orthotics, prescribing orthotics, teaching biomechanics during my Biomechanics Fellowship, was that the Blake Inverted Orthotic definitely made people pronate less, and we thought because of the inverted heel. Once I established my practice in July of 1985 in Sacramento, which was home for me, I again started ordering the Blake orthotics, and was happy with the results in most cases. But again, it was a very different orthotic than a Root orthotic, and also it had its own special problems of being somewhat more bulky. And I was looking at the time for a way to try to get the same results that I got with the Blake orthotic. A way I could simplify the Blake orthotic to get the same inverted heel shape. One of the things that I had already known at that time, I had been working on the subtalar joint axis location, so I knew about that and knew that we had to get more weight on the heel medially than laterally to get more pronation control medial to the subtalar joint axis. I also had completed the study on the anterior axial projection, where I saw that the medial tubercle was the weight-bearing surface of the plantar calcaneus. It was a broad, rounded situation that would probably accommodate an inverted heel fairly well, instead of having two knobs on the ground as it was pictured in Root's and Scarlatto's textbooks on biomechanics. And I also had started to develop my ideas further about the rotational equilibrium and how an inverted heel orthotic would be able to treat pronator-related problems in the patient's foot fairly effectively. But it wasn't until approximately 1990, early on in 1990, when I was giving a lecture on the Blake Inverted Orthotic, and one of the people from the audience who had come down, he had been trained at the East Coast, was now practicing in the West Coast, and had come after my lecture and talked to me and says that what he did when he had a similar patient that needed an inverted heel, he would use a Levy mold type cork and leather orthotic, and he would just put a varus wedge under the heel of the orthotic in order to achieve that same effect. And for some reason, this discussion made a light bulb flash in my head that, wow, what if we were able to just invert the heel of the cast of the foot without having to do all the time-consuming modifications that would have to be done using a Blake Inverted Orthotic technique. And so soon after that time, I was traveling twice a month from Sacramento to Lodi, which was about a 30-minute drive for me, to Precision Intercast Orthotic Lab, and the owner was at the time Paul Rasmussen. And I'd been working with Paul for the last 3 or 4 years, starting to write newsletters for him that eventually became our newsletter books. And I had approached him at the lab one day in early 1990 about this idea, why don't we try to shave off some plaster on the medial plantar aspect of the heel in order to get the same Blake inverted orthotic effect, but without all the extra plaster being added to the arch, the extra long nail and the first metatarsal, and the other modifications that really change the shape of the orthotic so much away from what the original foot was. And so Paul and I worked together on this for a couple of months until we came up with the modifications that I wrote in my paper that was published in April of 1992 on the medial heel skive technique in the Journal of the American Podiatric Medical Association. And this technique involved taking the positive cast, and what we did, we're going to take the positive cast and we're going to divide the heel into thirds, and at the medial third we're going to take a file to shave down in depths between 2 to 3 to 4 to 5 or 6 or even 8 millimeters, and then we're going to take a plaster file after that. So here we've cut down on the heel of the cast, and then later on the next step would be to take a file and shave a 15-degree varus angle in the heel of the positive cast, and then the edges around it to produce a varus wedge heel without having to do the Blake inverted technique. And this medial heel skive technique, which I named and the paper was eventually published in 1992, is something I'd actually used for a full year in my practice to make sure that it wasn't hurting anyone. And in fact, once the paper came out and other people started using it, they started commenting that they were very happy with not only the extra pronation control this inverted orthotic technique produced, but also that it a lot of times made the orthotics more comfortable than if they had not had it in. And so this progression from the Root explanation, where all orthotics should be vertically balanced at the heel and that you shouldn't be inverting the calcaneus, you shouldn't be messing with the orthotic in the heel for any reason. I then got introduced, luckily had the time to spend time with Rich Blake and see the results, the better results I got with the Blake inverted technique. And then years later, in 1990, approximately 7 or 8 years since I'd first seen the Blake inverted orthotic technique being used, I used it myself, invented this medial heel skive technique as a way to simplify the Blake inverted heel from the orthotic to produce a orthotic that would still have a varus wedge, but you could still do a forefoot valgus correction and they could still balance. It would still have this much of the same contour, but just would have an inverted heel. One of the interesting things about the medial heel skive is that, like I said, many people find the arch height of the orthotic to be more comfortable after using the medial heel skive. And I believe that much of this comes from two things. First of all, by producing a varus wedge effect in the heel cup of the orthosis, you're putting extra external subtalar joint supination moment on the orthosis to produce a more supination effect on the foot. So in other words, we're taking, let's say, a standard orthotic, and we're taking a standard orthotic, which would be here, and then the medial heel skive orthotic here. And as you produce that varus heel cup shape in the orthosis with the medial heel skive here, we're shifting the center of force of the orthotic more from being centrally located underneath the subtalar axis to be more medial to the subtalar axis. And this produces a supination effect that may supinate the foot away from the medial arch of the foot. The second thing that may improve the medial arch comfort with the medial heel skive orthotic is that the medial heel skive orthotic actually produces a slight heel lift, because we are shaving plaster from the medial aspect of the positive cast, which is in effect going to give us a little bit more of a heel lift in the orthotic, so that now it's almost like putting a pad in the medial heel cup of the orthotic. And this is actually in the paper, in the final pages of my paper. I actually talk about a way to simulate the medial heel skive by taking multiple layers here of moleskin or tape or even Corex or EVA blended into an existing orthotic to produce a medial heel wedge varus effect in the existing orthosis, and you can see here how this would produce a slight heel lifting, which I think this heel lifting may also explain why the medial heel skive does decrease medial arch discomfort in many patients. The other thing that I do with the medial heel skive is I'll use anywhere between 2 to 3 to 4 to even 6 millimeters now, whereas before I'd used higher amounts and found they became less tolerable. I'll tend to use higher amounts of medial heel skive in children who have a fatty heel. If I have an older adult who has fat pad atrophy, I'm a little reluctant to do anything over 2 millimeters of medial heel skive, thinking that possibly the extra push on the medial heel may produce more symptoms. I also will tend to invert the heel of the orthosis also with medial heel skive to try to get extra pronation control, because inverting the whole cast will produce an increase not only in the varus heel shape of the orthosis, but also an increase in the medial arch height. The other thing that happens with the medial heel skive versus the Blake inverted technique is that with children that have a very rounded heel, the medial heel skive I found to be much more effective. In this part of the medial heel skive paper, I actually talk about this, where if we take a child's heel that's very rounded here versus an adult's heel that's very flat, when we start to invert these a certain amount, you'll see how the flatter heel, when we invert it with the Blake technique, we produce quite an increase in varus shape. But with the child's heel, we don't produce much of a change in the varus shape of the heel because it's so rounded, so spherical. And so the medial heel skive gets around this limitation of the Blake orthosis by actually shaving plaster off in the medial calcaneus to sculpt the correct amount of varus wedging that is necessary to achieve the desired therapeutic effects and anti-pronation effects from the orthosis. So this is just a brief summary of the history of the medial heel skive and how it was developed. I started, again, to summarize, I initially was trained on the Root technique, where it was emphasized that all orthotics should be vertically heel balanced. I was lucky to have Dr. Rich Blake experimenting in his Biomechanics Fellowship with the Blake technique, inverted technique, and I was one of the students that helped him make many of those orthoses, along with my fellow runner classmates from the CCPM Class event in 1983. I started to use the Blake technique, saw that orthotics don't need to be heel balanced vertically. I also started doing research on subtalar axial location, on the interaxial view that allows us to see the shape of the plantar calcaneus, was working on the theory of rotational equilibrium. And with all these ideas and observations coming together, it was in 1990 I started to go back to Precision Intercast lab, and Paul Rasmussen, the owner of the lab in Lodi, we started experimenting with it, and then a year later I submitted the paper for publication, which was then published in April of 1992. So this was a full 25 years ago. The paper was published. The medial heel skive, I'm very happy that now when I do lecture internationally, I see the medial heel skive being used routinely throughout the world in patients that need to have extra pronation control due to their medial deviation of the subtarsal axis or extra pronation related mechanical symptoms. And I feel that I've made one small contribution to the not only the literature but also to the practice of custom foot orthoses by developing this medial heel skive technique. And I also have honored that the medial heel skive has been used by many pre-made orthoses. The medial heel skive is used in many pre-made orthoses that are available for purchase over the counter in order to produce better results from these with these type of pre-made orthoses. Anyway, that's the end of this lecture. I'm hoping to cover more topics in later lectures and in a historical fashion to give all of you a better view of the development moving from root theory to tissue stress theory. Thank you.